Okay, guys, we're going to go over neurological frames of references. Today, we're just going to focus on the NDT as well as the Rood as well, and we'll focus on Brainstorm and PNF for next week. So there'll be two separate videos. This will be the first video, just focusing on what we need to know for Wednesday's class. So today's objectives, we want to describe major neurological frames of references in terms of their uses and related tools and techniques. We want to recognize examples of when to use the neurological frames of references as appropriate. Describe and recognize each of the following are related to the neurological frame of reference, including theoretical assumptions, function and dysfunction continua, and indicators, as well as postulates regarding change. We're also looking at applying the neurological frames of references to a case study, and that'll be done in class starting on Wednesday. So for neurological motor control, we're looking at a mixture of traditional concepts as well as newer concepts. So with the traditional concepts, we're looking at reflexes occur in response to a stimuli. So reflexes and movement patterns change during development. Remember those reflexes that we learned in growth and development. And we're looking at the hierarchical control and motor programming. These are movements are controlled top down. So from the higher centers of the nervous system, exert control over the lower level parts of the nervous system. We're looking at motor control is cephalocaudal and proximodistal. So if you guys remember again from growth, cephalocaudal is head to tail, and proximodistal is inside to outside. As well as with motor programming, voluntary or sensory stimuli is initiates movement through development and learned experiences. And also to remember the brain is plastic, so the idea of plasticity in the brain. So with neurological motor control, the contemporary concepts is the degrees of freedom. So muscles and joints can be used in various combinations to create movement. Each movement is unique and cannot be exactly recreated. So the idea of doing an example of this would be like doing a bicep curl. Not every single, if you do a set of 10 bicep curls, not every bicep curl is going to look identically the same. So think about when you start the bicep curl, you might be able to lift it longer, lift it for more repetitions, that sort of thing. And when you're to this 10th repetition, it may be slower. You can also look at it as if you were to change weights in the bicep curl as well, it would be different. We're also looking at movement is difficult to reproduce. So gravity can affect how a body moves depending on positioning. Muscle endurance and or fatigue can create different results. So kind of that example of that bicep curl as well. We will also look at this with manual muscle testing and passive range of motion within kinese as well. We're also looking at the heterarchical control. So heterarchical control is person-centered, nature of tasks, conditions, and environment all work together to create movement. So it sounds a lot like what we had talked about earlier on in this class about the person, environment, and occupation, the PEO model. This contributes to the emergence of movement. So we have under the heterarchical control, we have emergence and control parameter. So with emergence, we're looking at spontaneous occurrence of complex motor actions that come out of a heterarchical control as opposed to a top-down control like hierarchical movement. Then we have the control parameter, which the change that alters the pattern of motor action. And then we have attractor states. Attractor states is the central nervous system is not the center of command for movement, back to interaction of the person, task, and the environment. So more freedom to consider what is causing the abnormal movement patterns. So with neurological motor control, we're looking at central nervous system damage leads to individual using compensatory techniques to function. Movement patterns occur due to dynamics between abilities and limitations. And we're going to note where compensation is occurring, then determine how to change the environment or remediate the individual. So it's very CNS driven. However, if the environment or task changes, movement patterns may also change as well. Okay, so we're going to talk about the neurodevelopmental treatment. So NDT. This treatment, you work predominantly with stroke patients, but it also can be used for CP, so cerebral palsy, as well as different types of head injuries as well. So your basic concepts of NDT. We're looking at neurological techniques providing remedial strategies. It's used in cases of central nervous system dysfunction. And the theoretical basis is for NDT. It's also referred to as BOBATH. So it's referred to as BOBATH due to its creators. Of course, you know how everything's named after whoever creates it, and a couple with the last name BOBATH created the NDT approach. So with developmental theories, it's developmental progression. So what developmental level is the person performing at is the question that we're trying to answer. We're looking through the lens of neurology as well as other developmental theories. It's an emphasis on handling techniques for the therapist. So you as a therapist, when using/trained in NDT, will be doing a lot of manipulation of the patient. So our theoretical assumptions for NDT is we're remediating foundational skills before normal complex skill acquisition is possible. So we're learning basic movements first, then more complex, and then integrated into function. This makes normal skill acquisition possible. We're experiencing quote unquote normal movement leads to learning normal movement. So promoting normal movement patterns and learning the sensations of the normal movements that they're doing or the patients are completing. We're looking at postural control is essential for limb movement. So again, kind of the idea of pelvis, that idea of the pelvis, a stable proximal base equals a better distal function. So mobility on stability. So kind of the example, I believe I gave it in growth of if you have a kiddo that's needing assistance with handwriting, let's say. As a therapist, I would look at what their core strength is, all those types of things. So looking at the proximal areas before moving to the distal areas. We're looking at normal movement cannot be imposed on abnormal muscle tone. So muscle tone can only move typically once you normalize the tone with inhibition or facilitation. We'll talk about those later in this presentation. So just remember inhibition and facilitation. I believe you guys have started learning that in Kaylee's class as well. Their facilitation and inhibition will help counteract abnormal patterns with appropriate sensory information for normal motor learning. Also important to remember that the brain has plasticity. Sensory motor impairments affect the whole individual. So sensory processing is a factor that we need to look into. So the need to be able to obtain and process sensory information to move. So we're looking at both what's referred to as feedback and feed forward. So movement linked to sensory processing through feedback and feed forward or anticipatory control. So feedback is you're experiencing sensation and then you're changing that movement. Feed forward or anticipatory control kind of says it with the anticipatory control. So you're anticipating the sensation and changing the movement based on that anticipation factor. Okay, then we're looking at function and dysfunction continua in regards to the NDT. So we're looking at axial control, so the head, neck, and trunk control. These are key handling points of control. So think proximal like the scapula, the pelvis, the sternum, and the head. We're also looking at automatic reactions. So the idea of equilibrium, righting reactions, protective limb extension, those type of things. That's a developmental progression. We're looking at limb control with a focus on the scapula and pelvis mobility and stability in regards to balance. So kind of the points of control. We're also looking at range of motion and dissociation of movement. With range of motion, we're looking at flexibility of a joint. Is the muscle innervated? Need to work through complete range of motion to develop ability to function throughout the range. Concept of elongation related to mobility. What produces the move or the change in the mobility? Mobilizer is characterized by the ability to act within the range, speed, and accuracy, as well as the limitations by muscle stiffness, aka tone, soft tissue contracture, fascial restrictions, etc. Then with the dissociation part is the ability to differentiate movements between the various parts of the body. And that's going to indicate the level of CNS maturation and separates movements between segments of the body. We're also looking at alignment of patterns of weight bearing. So alignment, think of arrangement of body segments. So each segment of the body relates to other segments. We're looking at muscle tone, which what does tone look like at rest? How does it change in varied positions and in response to different stimuli? We're looking at balance and postural control. So with balance, we're looking at the ability to move off of the base of support for dual purposes of stability. And orientation and control of the body position in space, requiring range of motion, alignment, muscle recruitment, and strength. Then we're also looking at coordination, which does the body move in a smooth and coordinated manner? This is the question that we're trying to answer. So some more indicators of function and dysfunction for the NDT. We're looking at overall reflex development. So are the reflexes appropriately emerged or integrated, and they're evaluated throughout observation. Then we're looking at automatic reactions. So even if they have an automatic reactions, what is the quality of that automatic reaction is what we're asking. This is also evaluated through observation of the quality of movement that your patient's giving you. We're looking at different synergies. So synergies are coordinating activation of muscles during movement. So the brain needs to connect with the muscle correctly to coordinate movement in an effective way. It's evaluated using clinical observation of positioning and movement patterns. We're also looking at muscle tone. So we're looking at hyper or hypotonic. So tone, remember, is the tension in the muscle at rest. We're evaluating using manual and visual observation of resistance to passive and active movements. So think of your passive range of motion, think of manual muscle testing, that sort of thing. Dysfunction is typically indicated by stiff, floppy trunk or extremities. With range of motion, we're looking at full passive range of motion that indicates function. We're looking for contractures or deformities indicating dysfunction. We're looking at alignment and weight bearing. So think of alignment as the function indicated by symmetry on both sides of the body. We're looking at balance and postural control. So balance, we're looking at dysfunction indicated by the inability to maintain postural support against gravity, or by using compensatory postural controls. And we're also looking at coordination. So we're looking at function that is indicated by the ability to perform smooth and accurate movements. Then we have our postulates regarding change in regards to the NDT approach. So when we're talking about postulates regarding change, think of these as treatment approaches and intervention ideas of how to work with this specific frame of reference. So some postulates regarding change could be with an inhibition for hypertonia. The therapist can use passive elongation, reflex inhibiting patterns, different sorts of weight shifts, as well as different positioning techniques. To facilitate muscle tone in case of hypotonia, the therapist can use joint compressions, joint traction, manual resistance, as well as weight shifts in those. So the assumption is that tone abnormalities occur following brain damage that affect the posture and movements. And also there's incorrect information that's passed within the central nervous system. So think of the sensory stimulation factors that assist with the brain damage as your ideas of inhibition and facilitation. Also, joint traction is the movement of surfaces away from one another. So joint traction and joint compression are essentially the opposite. Joint compression, you're compressing the joints together. Joint traction, you're moving the joint surface away from each other. Some more postulates regarding change in regards to the NDT approach. To facilitate axial control, the therapist uses passive elongation, active weight shifts, passive pelvic tilts, as well as active axial rotation. And then to facilitate automatic reactions, the therapist uses reflex inhibiting patterns. So you're breaking up the reflex that may not be integrated. You're holding it in a static position. So this is not always super optimal for treatment purposes. You're also looking at desired combination of movement patterns as well. To facilitate limb control, the therapist uses dissociation of synergy patterns. So synergy patterns, an example of this is moving your arm and your shoulder hikes up, or if you move your hands, all of your arms start moving. Your brain is essentially firing to wrong muscles as it attempts to reconnect. It is an abnormal compensatory type of movement. You may also see synergy patterns such as the flexor synergy and need to break up tone. Then you're looking at reflex inhibiting patterns, limb and weight shifts, place and hold, as well as rotational and reciprocal limb movements. So rotational movements, think of using ball and socket movements, so not just flexion and extension. And then reciprocal limb movements, think of symmetry. So if you move the left arm, you need to also move the right arm. And if you move your left leg, you also need to move your right leg. Move it at the same time in opposite directions. So think of legs and arms when walking. And to provide maximum amount of stimulation to encourage motor skills, therapists may adapt the environment according to developmental needs, level, and interest of the client. So now we're going to talk about the Rood approach. So the basic concepts of Rood are normal movement patterns emerge from the use of reflex patterns. So normal motor control emerges from the use of reflex patterns is a traditional view. And the use of these patterns generate sensory stimuli and support voluntary control during activity, which is conscious. The reflex pattern remains subconscious, so that movement is subconscious. And the idea is that normal movement patterns are subconscious and attention can be directed to the task at hand. There's also different muscles performing different movements. So your light work is the movement, so you're voluntarily controlled, and the heavy work is the stabilization, the reflexively controlled movement. Then our theoretical assumptions. So with the central nervous system damage causes misfiring between normal reflex development and normal movement patterns. Abnormal muscle tone is typically present, and posture is affected by muscle tone. So if normal reflex development doesn't occur, learned voluntary motor control also does not occur. Then our postulates regarding change with the Rood approach. Remember, postulates regarding change is very similar to referring to treatment ideas, intervention ideas, and those types of things. So we can use sensory stimulation that can elicit motor response. So that's facilitation. So think of icing, brushing, stroking muscles, that sort of thing. Especially with the proprioceptive system, think of joint compressions, quick stretching, tapping, pressure, and resistance to movement. And then with sensory stimulation can normalize muscle tone with inhibition. So that's slow rhythmic movement. Think of neutral warmth, maintain stretch, that sort of thing. Um, Current development as a starting point, then progress through normal motor development sequencing, uh, and focusing attention on goal or purpose of activity. You can also do what's referred to as sensory stimulation through the olfactory system, gustatory, auditory, as well as visual stimuli. You can both facilitate or inhibit those. And minimal voluntary control and abnormal tone and reflexes are present. So some more postulates regarding change. We can provide opportunity for repetition. Repetition reinforces learning. Treatment is sequential. So evoke muscle response, then use the response in developmentally appropriate movement patterns to purposeful movements. So you're going to use your inhibition facilitatory techniques to get the patient ready to complete an occupational task. You're going to start at the highest developmental pattern the patient can manage, and they may struggle at the next level until satisfactory. So they may require sensory stimulation as well as manual assist to get over that curve. And we're going to go ahead and end there for today's lecture. Come with questions to Wednesday's class. What we'll do on Wednesday's class is kind of answer questions, maybe do a little review, and then we'll open up some case studies. I hope you guys have a good rest of your evening or morning, and I will see you guys on Wednesday. Thanks.